The broadcast is now starting. All attendees are in listen-only mode.
It's 12 o'clock.
Hey everyone, we are just waiting for everyone to log in, so we'll just wait another minute or so as you all log in. People are furiously logging in as the numbers go up. This should be a very well-attended webinar. Thanks for joining us today. Once again, if you're just joining us, thank you for joining us. We are just waiting about a minute or so to let everyone fully log in, get their audio set up and screens, and we'll get going in about 60 seconds. All right. Thank you very much for joining us here at the Collaborative Family Healthcare Association. I'm Dr. Naftali Serrano. I'm the Executive Director of CFHA. We are pleased to have you join us for this very important webinar, Chronic Pain 2.0. And as you can see from the slide there on your screen, really a really unique, important, value-based approach to dealing with pain that Dr. Patty Robinson is going to take us through today. So I know there's been a lot of anticipation. We got really a record number of signups for this presentation, so we're all really excited. I'm not going to talk really too much here at the beginning, other than a few housekeeping items and reminders, and then we'll let Patty take it away. First, a great new feature here are handouts. Patty's been kind enough to provide some handouts. We've emailed those to folks who registered, but if you also just want to download those directly right now, you should be able to see a handouts sort of tab on your control panel, and you should be able to download those handouts from there. So check the handouts on the control panel. The other thing you can look at on the control panel is the questions tab. You can put any questions you like there on the side, and as you hear Patty's talk, feel free to ask questions, and we'll aggregate those at the end for Patty to respond to. The only other sort of announcements that I want to make are related to CFHA's annual conference, which is in Rochester, New York this year, October 18th through the 21st. It should be a great conference. Patty is going to be presenting at that conference on a great topic as well. Registration is opening next Friday, not this Friday, but next Friday, June 15th. So make sure to get on and get registered quickly and make your plans for October in Rochester, New York. Should be an outstanding conference. For more information, it's easy to find us at integratedcareconference.com. That's integratedcareconference.com. Last but not least, this is sort of a pre-announcement. We're going to be launching a new way for CFHA members to connect with each other, a social media, Facebook-like way to allow people to connect and find each other a lot easier across our membership. We're growing to become a much larger organization, but we want people to remain connected in important ways. So we're launching a new app called Social Link. The app's available on the iPhone and Android phones as well. If you just look for the app called Social Link, you will find it. And then you just sign in with your CFHA sign-in information and you're set. You're ready to connect with other CFHA members nationally. So that announcement will be coming out on Friday, but you can sign up as early as today if you like. Again, that's CFHA Social Link. Well, without further ado then, You all are here to hear from Dr. Patty Robinson. If you're here, you probably know already how important she's been to the integrated care movement, how much she has brought from the world of acceptance and commitment therapy to the world of primary care. And that's where this presentation comes in. It's the nexus of this ACT-based thinking with this very grounded approach to providing real interventions in primary care for chronic pain patients. So Patty has written a slew of books, articles, has done great consulting on a variety of topics. So she is well qualified to talk to us today about chronic pain. So I am very appreciative for Patty. Patty, thank you so much for doing this, and we look forward to hearing what you have to say.
Thanks, Naphtali. It's an honor to be able to kind of share some ideas with everybody listening in today. These are things that are, very important to me. So thank you for listening. Let's see. Yeah, I'm an author, and I work as a consultant for Mountain View. And so objectives today, really what I hope is to kind of affect your conversation that you typically have with patients that are experiencing pain, chronic pain or persistent pain. And to kind of, it's so easy, at least for me, to just get into automatic and do things kind of in an automatic kind of way. So we all have our phrases for working with pain patients. And I think some of those interactions are pretty uncomfortable. So we kind of develop, a little bit of autopilot in those situations. So what I'd like to do is kind of get you to add in some different kind of phrases. So there is one handout that will kind of help you with that, and it's called What's Your Pain Story worksheet, and it's available under handouts, but we'll get there in a minute. But that's kind of what I hope to do, and then I want to introduce some interview questions that I think are very useful to keep us moving along as we interview patients with persistent pain, so that we very quickly can come to agreement with the patient about the impact of pain on a person's body, mind, and social experience, so that we're set up to provide kind of a biopsychosocial intervention that makes sense to the patient. I also want to share kind of my thoughts about this HEAL approach to conceptualizing treatment options and planning care with the patient. It's an approach that really focuses on 4 different paths that a patient could take at any point in time that makes sense to them, and they might work one area and then come back and see again and work a different area. So a very flexible kind of approach that gives the patient a lot of choices. I will be presenting on this topic at the conference in the fall, and we'll have worksheets for each of the letters, the HEAL, that I can share with you by that time period. I also hope to make some videos over the summer and put them up on YouTube, so that you can have an example of using these worksheets and start to experiment with them. And then if you come to the presentation in the fall, you have a chance to kind of talk about what's working, how it's working, and ask your questions about that. And then, just in concluding, I have a lot I think I'm going to do today, is just help you kind of anticipate a population-based care approach to intervening and preventing problems with persistent pain, and provide you with some transparent tools like the Bullseye Care Plan and My Life on the Matrix. Those are both on the in the handouts too. We won't go into detail about those, but they're there for you to play around with. And the Bullseye is really an awesome tool that you could probably use pretty quickly. So the problem is that more people suffer from chronic pain or persistent pain than diabetes, heart disease, or cancer combined. I don't know if you are aware of that, but that's a huge problem. And then you think about, okay, so we have all of these people struggling with this problem. Where did they receive their care? Well, most receive their care from primary care clinicians. And how do these patients compare with like pain patients in tertiary settings where we tend to have more biopsychosocial kind of interventions readily available? They're actually complex and more complex, and they have more pain than patients in those settings. And then in primary care, we have medications readily available, a very common treatment option. PCPs are increasingly being encouraged to reduce use of pain medications for non-malignant pain. And this is good, but the setting kind of has the expectation for patients that they're going to receive medications, and most patients with persistent pain are at risk for addiction. So I think this is one thing that really contributes to our struggle with having conversations with patients that have pain and are taking medicines, or have taken medicines or wanting medicines, seeing that as part of the solution. I think we have to kind of think about the situation. And this guy named Robert Proctor has kind of influenced my thinking. And I found reading him a little bit helped me kind of come up with a conversation that I think I can honestly have with patients about this, what I would call the pain of ignorance of pain. So he teaches a course called The History of Ignorance, and he describes this field with the term agnotology. So he says agnotology is the opposite of epistemology, the study of knowledge. And Dr. Proctor says that ignorance is not simply being without knowledge. Instead, he says ignorance is actually something that's promoted by people and companies that benefit from misinforming the general public about what is known about a problem. A good example of this would be the tobacco industry, who for decades influenced public understanding of really scientifically established links between tobacco use and cancer. And they really effectively skirted the issue for decades, arguing that one could not really know anything, and that any number of things could lead to a health problem. So I think agnotology has also been at work in the area of chronic pain, as pharmaceutical companies and a few out of the mainstream medical professionals have promoted misinformation about pain and its treatment. Specifically, I think they've suggested that people should be pain-free and that use of medications is the way to achieve this goal. They've said that pain medications do not lead to dependence, and they can be prescribed without concern for significant side effects. And they even influence accrediting bodies to require that doctors ask about pain at all visits for a number of years. And they influenced a few patients to pursue lawsuits against doctors that didn't provide medications to solve the problem of pain. As a result of this campaign to spread ignorance so that a few could derive significant financial benefit, many people in good faith started taking and became dependent on opioid medications, these medications that science says are ineffective treatments for chronic pain and may actually worsen the experience of pain by further increasing pain sensitivity. So, the pain of ignorance and then the science of pain. The epistemology of pain involves knowing what science says. Pain is of value to human survival. Pain is a natural part of aging. Pain need not interfere significantly or permanently with the quality and meaning of life. Using what we know about pain to assess and learn skills for working well with that makes a lot of sense. There's a lot of freedom possible when a person learns to experience and work with pain on a moment-to-moment basis with an attitude of curiosity and interest. I think this effort to develop this type of perspective on pain does require acceptance of pain, but it's not a passive acceptance. It's really a very active acceptance that allows us to fully experience and honor other feelings that come with pain, frustration and sadness. Learning to respond to pain based on what is known about pain also requires development of an attitude of compassion for self and for other people and for our experiences, similar and different, regarding persistent pain. So the challenge is really to see what is complex as complex. And this is something that our human brains don't do all that well. Whether we're a person with persistent pain or chronic pain, or we're a clinician, we tend to simplify, to see things as either or, normal, not normal, good, bad, dangerous, not dangerous. And really the pain experience at the individual level and the interpersonal level and at the level of science, the truth is there's lots of gray. There's lots of gaps. There's lots of things we don't really understand. So if we're to see things as they are, as complex as they are, we have to be willing to let the gaps be there. And I think that requires us to build our psychological flexibility and notice our tendency to kind of make it either or, simple, and move on. If we can build psychological flexibility, and I'll talk more about that momentarily, then it's quite possible to have pain and to live a meaningful life, a vital life, and take pain along for the ride rather than allowing pain to be our ride, which it can easily become. So one of the things I encourage is that we look at our ways of intervening and look at the extent to which we are engaging patients, and do they leave our visits with a change plan that they're confident in and that they're going to implement, because it's the bottom line is behavioral variability. If we want something different in life, we have to do something different. So I'm a co-founder of Focused Acceptance and Commitment Therapy. This is an adaptation of Acceptance and Commitment Therapy, or ACT, that developed in parallel with acceptance and commitment therapy, dating back to the early 90s. In this approach, there's a focus on unworkable results of following rules that we may not even be aware we're following. there's a lot of, kind of crazy rules out there in the culture that we're all influenced by, like, we should be happy, we shouldn't have pain, that we're not really aware of. And they may have big consequences on the way we live our lives or don't really live our lives. Also to focus on emotional and behavioral avoidance, because all of us, pain or no pain, are avoidance machines. Doesn't always work for us. So the other kind of things about acceptance and commitment therapy include being able to kind of like accept, know what's happening inside our skin and kind of around us, and accept uncomfortable thoughts, feelings, sensations, and really choose our course of action based on what's important to us. So an approach to life where our values are our guides, rather than avoidance of pain or suffering or sadness or fear. And then to take actions. So we talk about committed actions and the ability to kind of benefit from our direct experience and see what happened as a result of that action. So to be able to learn from our experience. So what does science say about ACT and persistent pain? Well, the news is really good. Says that ACT is robust, and we have randomized controlled trials at this point. We have effectiveness studies, and we have kind of mediation studies that look at the core processes of ACT protocols, acceptance, committed action to values, mindfulness, and to see these core processes facilitate the positive outcomes observed in the studies. And the positive outcomes include reduction in perceived pain levels and improvement in overall functioning. So science says also that ACT interventions delivered in very brief formats, specifically 4-visit group format, to patients with pain in primary care clinics look pretty good. Small sample size, but they outperform treatment as usual in measures of disability, depression, pain acceptance, and emotional functioning. So I think ACT can be very helpful in a variety of concerns related to persistent pain. And it can be delivered in brief primary care group and individual interventions. That's certainly my background as a clinician. So I really encourage you to learn more about it. Now, I mentioned this handout, and you'll see it. It's let me see. It's called the ACT contextual interview. So the FACT contextual interview really concerns two contexts. The problem, should be the life context. That's love, work, play. In the problem context, time, triggers, trajectory. So this is a very fast-paced kind of social interview that you could probably get through in 10 or 12 minutes. Kind of keeping the pace up helps the patient with persistent pain be more present in the present moment. Many times the patient is really operating in the story about pain, and in operating in the story about pain, their behavior, the verbal behavior is very practiced and old and automatic, and tell a long story, but it doesn't benefit them. So this interview gives you a chance to do something different and to really identify the strengths of a patient as well as skill deficits. So you're starting to very quickly in the first 10, 12 minutes conceptualize interventions that might be helpful to the patient. And also you're understanding that story that the patient has about pain and the impact of the story. So you're thinking about what kind of shift or redefinition or small change in that story that's kind of coming through might be made that would better engage the patient in a behavioral experiment. So you can take a look at that, and I hope you'll kind of practice with it and, start to get that pace down and that feeling, because if you get those questions down, you can keep the pace up and you get a lot of information out there without thinking so much of what am I going to ask next? You know what you're going to ask, and then it's easy for you to kind of be more in the moment when you're working with patients and better attend to their nonverbal behaviors and help them kind of show up right now. So one thing I wanted to say is I kind of shifted from talking about chronic pain to persistent pain. And that's because I think it'll help us change our conversations about pain. And you might, what's my reasoning on that? I think that in a small, insignificant kinds of ways, probably more than one, persistent pain supports more hopefulness than chronic pain does. Chronic pain is an old term, and while I don't think not intentional, I do think it invites a negative view and a bit of fatalism. Chronic pain is also associated with the misinformation campaign that caused needless suffering, caused excessive disability to thousands of people, and it brought life to an end for many hundreds of people. And even today, it will take a life in cities and small towns across America. So it's my hope that the use of persistent pain will help you all develop new relationships with patients and help them develop new relationships with the pain that they suffer. I think persistent pain is a more descriptive term, and as such, it invites less resistance and struggle, and maybe encourages more acceptance and frees up a little energy for patients to approach life with more creativity, more optimism, more hope. So, kind of help them move on through their book of life and create a new chapter. So experiment with that. Think about, persistent pain. Part of the new conversation. I think we also, in the new conversation, really want to talk more and more about what science says, and we need to talk the physiology talk. I don't think this is too complex for patients. And then we need to talk the vulnerability talk. So I would say something in terms of physiology talk, just explaining that nerve cells initiate pain sensations. They're in the peripheral nervous system. If they're there, they're called PNS. That's called a PNS, and it includes like nerves all over the body, except for in the spinal cord and the brain. And these are the central nervous system nerves. And I think patients can resonate to that. I think we can also talk about PNS nerve cells connecting the skin, muscles, internal organs with the spinal cord and brain, and traveling on fibers, much like trains travel on tracks, moving kind of north, so to speak, as a result of electrical, chemical kinds of events in the body. And they have special receptors that are sensitive to many types of stimuli, really anything that could be harmful or damaging to the body, so they're very helpful. These receptors are called nociceptors, and everybody has millions of these, and they're all over the body. They're in our bones, our muscles, our joints, they're in the membranes that cover our internal organs. And pain sensations start with the nociceptors traveling on electric impulses, and this called nociceptive pain. Its intensity varies from minimal to strong, and people use different words to describe it: sharp, throbbing, tingling, stinging, aching. And the nerve cells in the spinal cord, they're kind of like trained conductors. They filter the signal coming in from the nociceptors, and they prioritize which go to the brain and how fast they get there. So like if you burn your hand on the stove, it's pretty fast, goes on the fast train. But if you have kind of just a little bit of an upset stomach, kind of a slow train. So, you know, these are all just perfectly normal kind of physiological processes happening in everybody's body. And then the brain kind of sends back a response. It's all so beautifully coordinated. It can be really quite complex and involve, you know, parts of the nervous system, different parts that help the person recover. It can affect the flow of blood. It can deliver white blood cells, platelets. It's just beautiful the way our body works. There is this problem called sensitization, and I think we need to talk with patients about that. And that's where it's a second type of nerve pain, and it involves damage to the nerve pathways or the tracts, such that they become persistently active. So we want to talk with patients about the physiology, but we also want to talk about the vulnerability factors as they relate to the experience of persistent pain. And the vulnerability factors include like human factors and then the individual story. So what do you think of these factors? Which one influence experience of persistent pain? You know, actually, science says that all of these factors play a role in our experience of pain. Our genes influence our sensitivity to pain and our response to pain medicines, pain treatment, like medications. They also play a role in vulnerability to development of nerve pain. Women experience pain more often and at more severe levels and more persistently than men. And then lifestyle factors are big, like smoking, problems with sleep, associated with more significant problems with pain. Psychological problems with mood are linked both with increased vulnerability to onset of persistent pain and with development after onset of persistent pain, if not present prior to development of a painful condition. Of course, life stress and social factors such as unemployment influence the pain experience. Long-term health problems increase our vulnerability, and our emotional reactions like fear play a role. And then our past experience with pain really is a huge factor, with the past experience of pain, an episode of pain, perhaps being the most significant factor in predicting onset of more problems with persistent pain. So still, you know, as we have this conversation with patients, patients are going to ask the question, you know, why me? And why did I get this? So I want to have you kind of, hopefully you can pull up that patient clinician worksheet, and I want you to kind of look over the different areas of that worksheet. And I'm going to give you the case of Mark, and I want you to assume that you just did this fact contextual interview with Mark, and you got all this information very quickly. And then I want you to kind of think about Mark's story. How's he putting it together in his life, what pain is, and also how is pain affecting Mark's biopsychosocial experience, and what do you think he might want to target first? So Mark is 38 years old. He's separated from his wife of 10 years, and he has limited contact with their 2-year-old son, Jason. He's a computer programmer, and he prefers to work alone, as he likes to innovate and develop things, new software. And then he sells his products. He's been less productive since the birth of his son. Jason had problems at birth and was in the hospital for several weeks. Mark felt very unprepared to help his son. He pulled away from his wife and focused more on a work project, hoping to kind of get his mind off it and generate more money to help with medical costs. And then during his second year, Jason was having more problems, was diagnosed with autism, had food allergies, and then Mark's lack of confidence just grew, and he didn't know how to relate to his son or his wife. His wife always seemed tired and out of sorts. And he started, working at night and sleeping during the day, and this just led to a lot of conflict with his wife. And he went to his doctor and asked for help explaining how anxious he felt and how the stress of the family situation made his pain much worse. And so the doctor said, well, I'll give you a prescription for a benzodiazepine, but don't take it. I don't want you to take it long term. It's only short term. And the doctor also increased his dose of pain medications and encouraged him to consider trying physical therapy again. Mark doesn't use alcohol, but he smokes marijuana. He lives in a state where marijuana is legal, so he doesn't see marijuana use as a problem. He also smokes tobacco and wants to quit. He does not use street drugs at the present time, but has tried heroin back a number of years ago before he met his wife. He had once been an athlete, but a skateboarding accident in his early 20s had put that to an end. At present, he eats poorly, mostly drinking juice when he's working, and then eating one large fast food meal a day. He likes soda and really found it hard to hear when his doctor recently told him that he had metabolic syndrome. The doctor also suggested that he lose weight, as his BMI was now 29. He explained that the extra weight was contributing to greater pain severity in his knee. So Mark had several knee surgeries, and he experienced persistent pain in his right knee and persistent pain in his left hip, which the doctor thinks is the result of his change in gait due to pain in his knee. So he tried physical therapy, but found it mostly increased his pain, and it certainly took him away from his work schedule. So when his wife accused him of overusing his pain pills and told him to get a different doctor and grow up, he felt really hurt because he knew he did use more than prescribed at times. And he also knew he needed to grow up. But Mark didn't know how. And his story about persistent pain, really just in a few words, is I don't know what to do. It just hurts too much to think about all the problems I have. So in working with Mark and using the worksheet, he and the BHC agreed that he would start by strengthening his body first. He thought with a healthier body, he would be able to learn the skills he needed to negotiate an increasingly complex life more successfully. Our patients are really very much like Mark, and Rosalie is another case example that we won't have time, I don't think, to go in to, but an older lady who's on a leave from work and is experiencing greater decline with more sedentary kind of lifestyle. And Rosalie's intuition was to start by strengthening her mind. She thought with a clearer mind, she'd be able to notice what's happening in her body and make better choices about diet and daily routines. So this worksheet is designed to help you start a conversation with a patient where they have a choice. They have the ability to conceptualize some options for pursuing a better life and to get that started. And then the HEAL approach really has 4 pathways that they can pursue. First, H for health routines. So that would include sleep, exercise, nutrition, connection with others. We know from the research on the experience of persistent pain and lifestyle factors that better sleep, greater activity, better nutrition, and better social connections are all associated with better pain outcomes. Energy is the second pathway. So with energy, where we're going is trying to help the patient shift their perspective on what energy is and to better experience energy and the lack of it and the variability of it as they go through the day. Also to enhance energy, even just for a few minutes by visualization exercises, which help them see themselves as moving, as acting for time periods as short as 1 minute, 5 minutes, 10 minutes. This also includes teaching people breathing techniques which create energy. There's a long history of pranayama, look it up, associated with different kind of breathing exercises that have a big impact on energy. And then stretching. So stretching in the sense of being able to be in the body and feel the body, understand what's happening in the body, and move the body in ways that release tension and generate positive sensations which are energizing. And then I think so important is the energy we all get from connecting more with nature, being outdoors, or even looking out a window and really tuning in to the different shades of green. Very important in this HEAL approach too is attention training, and I really encourage you to look at that field. Neuroplasticity is so important to patients suffering persistent pain. So noticing sensations, thoughts, feelings, naming them, and experiencing the present moment for 10 seconds, 1 minute, 2 minutes, and then returning when, as is always the case, we are pulled away into the future or off into the past, returning to just now and letting go of the sensations, thoughts, feelings that really draw us into the future or the past in a very, very strong way. And then the last part of the HEAL approach that I think will be helpful to working with patients with persistent pain is love. So, it's been said, love is all there is. And so many times our patients with persistent pain are very poorly connected with feelings of love, with their experience of giving love or receiving love. So I think in our work in this area, we can help our patients experience pleasure and to really to plan it and to experience it, and not only plan it and experience it, but catch it when it happens spontaneously, as it does every day. But given the way that our mind tends to work, looking at danger and scanning for pain, scanning for problems, we miss a lot of these spontaneously occurring moments. So I think we can help our patients better tune in to sensations of pleasure and embellish them and kind of keep them around, and in that way kind of change the way our brain is working so that it is in that healing place more often. Certainly experiencing our values is very energizing in terms of moving us towards connection and meaning, and then grit, keeping that values focus so that we have the ability to persevere and return again and again to doing what we think is important in life. Just in the last few minutes, I want to say I think we need a population-based care approach to persistent pain. So the PCBH model, Go PCBH, is kind of the platform. And within that platform, I think we can do a lot in the way of group services. So I think workshops, class series, and group medical visits are all very important ways of addressing this huge problem. I think we need to have a prevention focus as well as an intervention focus. So looking on the right side of your slide, you'll see the suggestion that the primary care clinician identify risk early on, 3 to 6 weeks after an illness or injury. And at that point, to be able to change the conversation from pain avoidance and to work skillfully with the patient to support an approach response. If this doesn't kind of move the patient, get them back into their life, then I think BHC involvement is indicated early on, probably with the patient and the family, so that the family can pull in the right way and support in the right way. Creating a team approach, using the bullseye plan, and perhaps also offering an optional workshop on using the bullseye plan for the patient and the family. If you're interested in a chapter on using the bullseye plan to help a patient with chronic pain, I can certainly make that available to Jenna or Naftali, and they can put it on the website so you can read more about that and develop some confidence in using that approach as a care plan. The bullseye also works very well for patients with persistent pain that need ongoing monthly support in group medical visits. I really used the bullseye for about 5 or 6 years in group medical visits, and it's just very rich what all you can do around that metaphor. That, along with one-to-one visits as needed with the BHC and medical care as needed. The last thing I wanted to encourage is the creation in our clinics of support groups. For every patient we lose to pain, the opioid epidemic, there are many people left behind whose hearts are broken, and that come to their primary care providers asking for help. So I think starting support groups for loved ones are important, and having within those support groups a focus on community healing and community growth and resilience over time. So, yeah, Led Zeppelin, love this song, Stairway to Heaven. So thought I would end with that. I thank you for your precious time, and have some time to answer a few questions.
Thank you so much, Patty. An awesome presentation, and just a great centering perspective for providers out there who are working every day with patients with persistent pain, and I do love that language. So thank you again. I'm going to read, Patty, a couple of the questions that were posted here. Jamie Lunsford asked, do you ever discuss with the patient the terminology of persistent pain versus chronic pain, or do you only model this in your own speech?
I think I would explain it, and I would explain my choice of the term persistent pain based on the mistakes that we've made as medical providers by not staying closer to science and really protecting patients. So I would say that with chronic pain, we were pulled into a misinformation campaign that really promoted pain avoidance and use of medications that were addictive and unhelpful. And it's part of my change in commitment to stay closer to science, to shift, to leave that behind and say that was a mistake and we're going forward. And persistent pain is something that we can live with. We can live a good life with persistent pain. And we can play with persistent pain. So I think I would explain it and the shift. And I would encourage everybody, whenever you read anything, be sure before you read it, look at who put it out and who paid them and what was the funding for that study. Because this isn't over. I mean, there are still people that would make money off the misfortune of others in healthcare. So we have to be vigilant.
Absolutely. So Judith Gonzalez has a question, Patty, and I'm going to sort of add on to her question a little bit because she's getting down to implementation, and she's wondering if you know of any grants to apply for the implementation of the model. So she's already thinking about getting this going in her clinic. So I want you to answer that question, if you know of any grants or funding opportunities. But on top of that, thinking about implementation, if you could give the folks some suggestions about how to implement this, not just in their individual practice, but across their clinics, maybe education for their providers, medical teams, et cetera. So those two questions. Do you know any grants, and how would you think about implementing this across a clinic?
Yeah, so take them in order. I think depending on how much money you need for implementation, I would look at local resources, local kinds of foundations that might be interested in a small way in improving the health of the community. And it's such a big deal to go after national funding that I think I would try local foundations or state foundations in see what you could come up with, Judith. The second question, I think I would take that slide that I had, the population-based care. I would just take this whole PowerPoint and print it out and talk with people at your clinic or teach it forward. Just go through the PowerPoint in a brief kind of way at a training. But you know, short of that, I would just probably go to slide 20 and maybe print that out and say, we could do any number of these things. And what do you think we should start with? Yeah. And I can, to help with that, generate interest, I can certainly share that book chapter on the bullseye and chronic pain, because that would further engage people in like, oh, this is how we would implement. Oh, they have in this clinic, this patient is part of a group medical visit, and this is what the primary care clinician does, and that's what the BHC does, and that's what the nurse does. And so they can envision it by just reading a really short chapter and using a tool that's very transparent. They don't have to know acceptance and commitment therapy to get it.
Excellent. Yeah, and that's the magic of it, right, Patty? That really the core concepts that we're teaching are mostly, in many ways, unlearning bad things we've learned about pain over time and then institutionalized in the way we do medical care. So it's not necessarily complicated, although it can be tricky, I think, to reorganize our approach and our thinking about it, not just from the patient side, but also from the clinician side.
Right. And I think, you know, given the pace in healthcare right now, it's really tough for our PCCs to, you know, look up and, you know, try something new. So a lot of times in my experience, it was by working as a BHC to shift some of the burden of caring for patients with persistent pain to myself by providing a group medical visit service that I did with my behavioral health consultant assistant, Tina Fuentes. It was when the pressure was off a little bit that the PCCs and the nurses were then like, oh, sure, yeah, we can talk about how to prevent this problem. Or, yeah, you're right, we should start a support group for people that have lost loved ones in this mess. Yeah, but I think, you know, probably implementation probably would start in a way that anything that is feasible that really relieves the pressure and increases the sense of this is workable, this is doable, will help you get to more change within your clinic.
Great. Thank you so much, Patty, and thank you everyone for joining us today. A question did come up about the recording, whether this has been recorded, and of course we do record all our webinars, and they're all available on our Vimeo channel, which you can find on integratedcarenews.com. That's integratedcarenews.com. And if you go down to the video section, there's a sort of a Vimeo widget there that has them. We'll be putting this up in the next couple of days, so you can get it there, download it, view it, do whatever you like with it. So look for it on integratedcarenews.com. So thank you again for joining us. One more reminder, if you want to hear more from Patty and from folks like Patty, remember to join us at CFHA in October in Rochester, New York. Thanks so much, and we will see you all at our next webinar soon.
It's 1 o'clock.
Patty, thank you so much.
Oh, you bet. Yeah, thank you.
Awesome work. We'll talk soon.
Okay.